No, it doesn't work. Thank you. So we've had a number of successes in the clinical trials. Is that better? And I would just like to highlight some of those. Dr. Yale Wong has been very successful as a principal investigator on the Resolute post-approval study. Sometimes we've entered up to 9 patients per day. We have 16 studies in the pipeline, and we have a number of our cardiologists that are involved in studies where we rank in the top 5 across the country, including Drs. Travers, Nickelbein, Melby, and Ekman and Chavez and Manunga. And we have 465 patients enrolled to date in 2017. Special thank you, if you're out there, Saeed Al-Sadawi in Waconia land, thank you for your referrals to the valve team. I understand you've eliminated valve disease in Carver County, and you're now working your way into Sibley and Lucere County. So keep up the good work, and thank you all for your support of our work. You might also see this week engineers from Bay Labs testing their new automated ejection fraction software in the Ecolab area. They're using clinic patients, and some of your clinic patients may participate in that study as well. So you're on. Dr. Davidovich, our senior fellow, is going to lead us through some, I'm sure, excellent case studies this morning. Thanks, Dan, for coming.
Thank you. Hello. All right. Hi, everyone. My name is Daniel Davidovich, and like Dr. Sharkey said, I'm one of the third-year cardiology fellows. Some of you might know me because we either work together or because this is the second time I've had a chance to come and talk at this meeting. Last time we talked a little bit about PA pressure monitoring. This time we're going to go with something a little more traditional for the fellows presentation. And first I had come up with a ton of cases and built the presentation, and I put so many videos into it that it kept crashing every computer I put it into it. So I've scaled it way down, and hopefully you guys will find the images here interesting, and we can review a topic quickly, and we'll see how much we can get through. So disclosures for this lecture, I have none, and of course always must have an agenda, even if it's a case review. So just as a reminder, we'll review a case, highlight some important points, and I really want to hear your guys' comments as we go through the case about what the EKG shows, what the echo shows, and if you would have done anything differently. So to start off, I'll start telling you guys about this patient. We've got an 82-year-old male patient, and this is the first time he's having any contact with your healthcare system. All of the care he receives is through the VA system. There's no records available on Care Everywhere and nothing on your Epic. But you do know he lives in a nursing home, a skilled nursing facility that's run by the VA, and he's been living there for a few years. He has a nurse that regularly cares for him, you know, and of course other nurses do too, but he's got one that cares for him more frequently, and that nurse was on vacation. They come back for a shift at 7 in the morning. They start seeing all of their patients, and when they get to him about mid-morning, they just kind of say, you know, he's not acting like his usual self. He seems drowsier than usual. He's got a decreased level of consciousness, and then they started worrying about possibly some right-sided facial droop. So they said, we're not going to risk it. We're going to call 911. They started looking through his chart there at the nursing home to see if anything had happened recently. They noticed he had had a mechanical fall the Saturday before, but it didn't seem like there was any head trauma, and he seemed to be doing okay after it, so he didn't go to the hospital for that. So he arrives in the emergency department, and the providers in the emergency department start trying to get a history from him. And really the only thing they can get out of the history is that he's got some left hip pain. But anything else, you know, he really can't give them much information. He keeps kind of falling asleep as they're talking to him. Sure. And I'll button this. Is that better? All right. Where were we? Yeah, so he keeps, as they're talking to him, he keeps falling asleep. And then when he tries to answer, they can't really understand. He just mumbles. Then he'll get startled and agitated. He can't tell them what medications he's on or about any diagnoses. But fortunately, they started making some phone calls. They were able to get a hold of his daughter, who is very involved, and the nursing home staff. And they start gathering some data, and what they find out is that this gentleman is usually ambulatory, able to do most of his ADLs. He's usually even setting up his meds with some help, eating by himself, toileting by himself, and that for the last couple of days, that really hasn't been the case. He started to get worse and started to have inappropriate speech, which they say, you know, he just would answer questions very oddly or in an unrelated way. And he's having us help him feed himself and use the toilet. So those were kind of the changes that they were worried about mostly. They were also able to give us a nice past medical history. We were able to find out that he does have some degree of dementia and has seen a neurologist for it, but that is very mild. He has some psychiatric illness. You know, he's got anxiety, PTSD, bipolar disorder. He's on medications for that, and we'll get there. And then he's also got some metabolic things, diabetes. He's not on any insulin for his diabetes, and he's not on any pills for his diabetes. So it's considered diet-controlled diabetes. And of course, high blood pressure, hypothyroidism, COPD, and GERD. So here's a list of his medications, and for a patient that's being presented in a cardiology conference, he does not have a lot of cardiac meds on his list. He does take aspirin, and I'm not quite sure, other than his diabetes and primary prevention, that there's any other reason that he's on it. And he's on an inhaler for COPD, some medications to help him sleep and for pain, like the gabapentin, a lot of psychiatric medications. The tamsulosin, there was mention that he had had some issues with urinary retention in the recent past, so he was started on that. And I don't know if that's, if they were hoping that would help with his blood pressure too. He's not on any other blood pressure meds. But another little detail to know is that a couple of days ago, meaning a couple of days before this happened and he wound up in the emergency department, he had been prescribed a 7-day course of ciprofloxacin, which he had completed just a couple of days ago, because he had gone to a clinic visit, had some urinary complaints. Again, he had been having some urinary retention, and he was diagnosed with a UTI based on a UA and a urine culture. From a social history, again, they mentioned he's been at this VA nursing home for 8 years. He was a veteran of the Navy, now retired. He had different jobs after leaving the armed forces, but nothing recently. He had a very remote history of tobacco use back when he was in the armed forces, a serious alcohol use disorder, but he has been in remission now for 8 years since moving into this skilled nursing facility. No recreational drug use, and again, this daughter who is his healthcare agent and is very involved in his care. So obviously they did a physical exam while he was down there when he first showed up, and as you can see, he seems to be hypertensive, and he also has a fever, but the rest of his vitals look okay. And then on exam, this is their exam. One of the big concerns, like we mentioned, was stroke. So you can see there some of the bolded areas where they're doing a neuro exam, trying to see if there's any laterality to his exam, if there's anything that they think might be a neurologic event. And then they also comment on this abdominal discomfort. From a cardiovascular standpoint, They comment on the fact he had an occasional irregular heartbeat, and then there's no comments on any murmurs or gallops or anything like that. So one of the first things that was done was an EKG, and I don't know if one of the fellows can help me out with the EKG just to get some participation going. Well, they're sitting together. We'll let them.
So looking at this ECG, it looks like sinus rhythm with a right bundle branch block. I think this would also fit with a left anterior fascicular block here. And then there's an occasional, what looks like a couple of PVCs that look slightly different from each other, so maybe raising the suspicion for polymorphic PVCs. QT is a little bit prolonged here as well. So.
Okay. All right. And I don't know if anybody else is seeing anything else on the EKG that they want to add. All right. Well, I agree with that read. The right bundle and the left anterior fascicular block are kind of the two main things that catch your eye. And I'm with you. The two extra beats, this first one over here and this one over here, seem a little different. I don't think I can see anything here to let me know if it's a PAC or a junctional beat. So I was kind of in the same shoes saying, well, they're a little different, so they might be coming from different places. But I think the conduction disease here is what's going to be important moving forward. All right, so that EKG was done very quickly right after he got to the ED, of course. You know, whenever they show up with, the patients show up with altered mental status, the EKG tends to happen quickly. So we've got a long page of labs here, and, a long slide with labs here. Now I think the highlights would be that his creatinine was 0.94, so actually a decent creatinine value. And then his lactate was 2.0. The upper limit of normal for this particular assay was 2.3, so it would technically be within normal limits. And then he had a white blood cell count of 19,000, and that was mainly driven by neutrophilia. They got a full metabolic panel with the LFTs, which were normal. They checked his TSH, given his history of hypothyroidism, and the fact that that he was coming in with this sort of decreased level of consciousness. And they got a UA, which is abnormal, but the caveat there is going to be that they actually had to use a Foley to get that UA. So that might affect what we see, and that he's had a Foley in recent weeks as well. Now, I know you're all wondering, there's one lab that we're missing here that people always get, but don't worry, it's coming. And there it is on the next slide. You know, you can't bring a patient in without a troponin, so we've got a troponin, and it was abnormal. Troponin level of 0.609. Mainly, you know, as I did some digging, again, this was in the setting of just altered mental status, and initially there was concern for a stroke with the facial droop that was mentioned from the nursing home. So since he couldn't provide a history, they went ahead and ordered a troponin level for us. They also drew blood cultures given his fevers, and they did that before giving him any antibiotics, and those are pending. I apologize. I wanted to put the chest X-ray in, but for some reason I couldn't. But essentially, it was a pretty unexciting X-ray. No acute pathology, maybe a left basilar atelectasis. Since he had this abdominal discomfort, they did a CT abdomen pelvis, and they didn't see anything concerning. And then since he had this recent fall, they also checked for trauma of the C-spine or the head, and they did not see anything acute. Now, the CT of the head did comment on an old infarct in the posterior limb of the left internal capsule. Again, with the altered mental status and the fever, they were also thinking about meningitis. So there was an attempt at an LP. but of course he was altered, and even as they were attempting it, he started getting agitated, so that was aborted. And they had planned an admission to medicine for additional management and workup, trying to figure out exactly what was going on. But then the patient started to get a little worse, and then shift change came, and they all went in together to see him for sign outs, and they felt like he was more altered. And the nurse mentioned he had been getting a little more tachycardic, into the high 100s. His blood pressure, he wasn't hypotensive, but when he came in, he was hypertensive. And then his blood pressure kind of started trending down a little bit into the 120s. So I think everybody was already a little worried and thinking they might need to be more aggressive. And then timing is everything. The lab called and let them know that there were gram-positive cocci in both blood culture samples. So of course the sepsis concern came up. At that point, they took him into the stabilization room. They decided that he was going to need to be intubated. He had already received acyclovir, thinking of meningitis like we mentioned, and then broad-spectrum antibiotics with vancomycin and meropenem. And then during intubation, he had some borderline blood pressures going down into around the 90 millimeter mercury systolic range. So they pumped up the fluid resuscitation. They were giving him some continuous fluids, but they went ahead and gave him a few boluses, and his blood pressure came back up to the 120s. At that point, they were able to actually do the LP, and they admitted him to the medical ICU team. Of course, the medicine floor wasn't going to work for him anymore now that he was intubated. So, of course, we were talking about how the nurse showed up in the morning for their shift, but then this gentleman was seen a little later in the day. He made it to the emergency department by around noon and made it up to the ICU closer to the evening. So overnight, there wasn't a lot of things that happened. He was essentially maintained in the ICU, off pressors. He was easy to ventilate. They kept following his labs, and they started working with the VA to see if they could get some records of what had happened recently. The VA was able to fax some records early in the morning, and they were able to see that a prior urine culture had Enterococcus faecalis. They, of course, consulted ID first thing in the morning, and then they trended a troponin. It went up, and then the standard order had the 4 checks, and so that was the last check at 1.280. They were done 2-3 hours, and we didn't have any troponins after that. And then he kept getting some fluid resuscitation, and his lactate kept coming down nicely to 1.1, then 0.8. Some of his CSF studies came back overnight, like the gram stain and the chemistries, and those were all reassuring and showed no evidence of meningitis. And so ID very quickly took a look at him and at his records and said, you know, knowing what the microorganism is, knowing that it's Enterococcus bacteremia, we would like to get an echo to make sure that there's no cardiac involvement. And then they also changed his antibiotics a little bit to ampicillin and ceftriaxone based on some of the sensitivities that were available. So he comes in to the echo lab, and that's where I at least kind of got involved in his care. And we've got the first echo pictures, and Michael, since you've got the mic right next to you, if you can help orient anybody who doesn't know what we're looking at here.
Well, okay.
Let's start
like
with
that
the
question.
view. Let's start with the view,
yeah.
and then friends
So
will
yeah,
help you
that's
out.
the first one, a long axis view showing pretty I'd say pretty okay LV systolic function, showing both mitral and aortic valve. I can see that at least the anterior leaflet mitral valve is okay. Posterior leaflet I cannot see much, and the aortic valve leaflets look thickened a little bit.
Mm-hmm. Great.
And yeah, I don't think LA might be a little bit dilated, but not sure.
All right. And yeah, no, so I agreed with the aortic valve. It definitely looks thickened there. And then like you mentioned, you can kind of see this anterior mitral valve leaflet, but then here you don't see the posterior mitral valve leaflet, and you see kind of this thing here that kept catching our eye. So the tech very nicely zoomed in on it and kept trying to get us better pictures. Of course, this is an 82-year-old gentleman with COPD on a ventilator, so it wasn't the easiest images. But you know, when you look at it with the zoom, you can kind of see that there's something here, and this over on this spot that flashes into view intermittently gives you the impression that it's perhaps independently mobile, and that might be a vegetation. Now, this is only one view, of course, and like I mentioned, when I was trying to put in all the pictures, I kept making a presentation that was so big it kept crashing the computer. So I tried to just give you guys the pictures where you could see it best, but as you can see, it's not a great look at it, and you know, the lung kind of gets in the way. This is a apical four-chamber view for those who don't look at too many echoes, and you know, these views are a little foreshortened too because they were trying to show us the vegetation as best as they could, and it kind of looks like there's something there, and there on this one is closer to a two-chamber, again very foreshortened to try and show us that vegetation. You can kind of see again that posterior aspect of the mitral valve annulus. There seems to be something there. So of course, and then we put color on that valve, and surprisingly enough, there didn't seem to be a ton of mitral regurgitation. Again, the pictures I know are very rough, and these were kind of the best that we could get. But as much as they tried to look at that valve and look for a good regurgitant jet, they were only finding very small ones. So at this point, what was reported was a technically limited study. Like you said, they reported a normal left ventricular size with a normal EF, no wall motion abnormalities. They comment on perhaps some fibrocalcific process of the mitral valve annulus, but then they also comment on a mass attached to the atrial aspect of that valve. And they make the comment that it's very suspicious for vegetation. We talked about the thickened aortic valve. He had a little bit of aortic stenosis, mild, with a gradient of 11.2. We couldn't really get a tricuspid regurgitation jet. And of course, we wanted to do a TEE. We called the cardiology team. We asked them to order one, and we put him on the schedule because we wanted to get a better look at this. And so I was involved in the TEE, and this is, you know, your picture on the left, this one here. That's actually just from esophageal intubation where the probe was. That was literally the first picture that came up. And again, it's not a traditional picture in any sense, but I thought it was, you know, I hadn't even looked at the screen yet, and we already had an image of it here, where you're already kind of seeing something mobile there that seems a little concerning. So we started just panning a little bit and started to see a bigger vegetation showing up there. So we'll get closer to the more traditional views. And again, very foreshortened views, so I apologize that it looks a little funny down here. But I was trying to find the ones that showed the vegetation more than the rest of the LV. And I thought this case was interesting because, I mean, this is a very large vegetation with a very mobile component to it. You can see that it's on the left atrial side, but it definitely kind of crosses over here across the valve with every beat, and then on the image next to it, you can see it again. Now, keep in mind that this gentleman's symptoms, other than the urinary retention issues he had for a few weeks, the altered mental status and those things have been going on for a couple of days, 2, 3, 4 days. So this is a large vegetation for somebody presenting with not a long history of symptoms, at least. And then here we go up to about 90 degrees, closer to what would be more of a 2-chamber equivalent to TTE. And you can see we've got our appendage in the front and then our valve here in the middle. And again, you can see vegetation pretty much going across the whole mitral valve annulus. If you imagine this connecting to this other side as you go around the circle, with a lot of very mobile parts of the vegetation right over the valve that keep getting pushed across the valve. And then over here, we started panning more towards the mitral annulus, where there seemed to be just not so much vegetation, but we were worried about an abscess in that area. The tissue didn't look normal, and you can again see that right over that. You've got all of these little bits of vegetation that keep moving independently. And then we kept seeing a regurgitant jet around the LA, but whenever we would look at the valve itself, there didn't seem to be too much regurgitation going across the mitral valve where you would expect it, across the commissure or anything like that. We found this little area, which we thought was probably a perforation, but it still didn't quite explain all the turbulence we were seeing when we were going around the LA and trying to look at the pulmonary veins and all these different things. And eventually, as we kept digging through that area that I mentioned looked like an abscess, we found this part where it seemed like you had a jet going through the abscess, from the LV through the abscess and into the LA. And when we followed that turbulent jet, it seemed to match what we were seeing before. So of course, if you think about it, if that area is the abscess area and you've got a fistula going through that abscess, with every beat, you're washing out that area and probably picking up some more microorganisms that you send into the circulation. At this point, of course, the diagnosis of endocarditis was pretty much made. We also knew we had surgical disease, and that's another one of the important points. In this case, you could have diagnosed endocarditis without a TEE. You already had your diagnosis with the TTE, but it was important for this gentleman to find out what type of disease he had, and for every patient, because it definitely can change how you manage the patient and whether they require surgical management. Now, in this particular gentleman's case, he was 82. He had some comorbidities that made him high risk. He had this history of dementia. So talking to the family, it really seemed like he wanted to focus more on the conservative side of things. So, they declined. They met with the surgeon. They met with cardiology. There were a lot of conversations that took place with a heart team approach. And in the end, they decided that they did not want to move forward with cardiac surgery in his case. But I did want to hear about what people thought. In my mind, at this point, this case, I think that the urinary side of things that we were seeing was probably more of an embolic situation rather than being the cause of the endocarditis. It looks like his urinary issues had started a lot more recently. I know the microorganism fits, but the way I was thinking of it, looking at that vegetation and how mobile it was, I think what we were seeing was an embolic an embolic manifestation of the endocarditis, and possibly even with the lacunar infarct, which was in an odd area for an embolic event, but as much as those vegetations were mobile, it certainly seems like they'd be at high risk. I don't know if anybody would have said, well, we can manage him medically. I think that this was clearly surgical disease, but if anybody disagrees, I'd love to hear a little bit more. All right. Looks like.
Well, you know, it seems, I'm not sure if we have any surgeons here. It looks like there's a lot of inflammatory tissue, and the patient's not in an overt failure. The abscess is being drained, if you will, but spontaneously with fistula. I'm not sure that the surgeons would want to jump right in on this and would like to see a period of antibiotics. You know, the problem might be that that whole annulus is very friable and not approachable for a primary reconstruction at this time. So I'm not sure it would be a cardiac emergency, mostly because the patient's not in fluid failure was that what the surgeons were saying?
Absolutely. He was considered, so we'll go into the differences in the guidelines in a little bit, but you're absolutely right. You've got the classification of who needs emergent surgery, urgent surgery, and not so urgent, but still kind of urgent surgery. He was classified as someone who could probably wait the 1 to 2 weeks that, for example, the European guidelines recommend on antibiotics, because he was still continuously bacteremic, and like you mentioned, he was, again, just getting reseeded over and over again from the abscess. So the plan would have been along the lines of cool him down with antibiotics and get him to cardiac surgery if possible. You're absolutely right. The surgeons were not excited about operating on him. They had him as a very high risk, and they commented on how much damage there was and that it would probably be a salvage operation. But even knowing all of that, the family kind of said, well, we don't think it matches what he would want, and they wanted to stay away from it. But you're absolutely right. It was something that would have happened later in time, and that would have been very high risk for their...
Most athletes are not seen well on TEE and our surgical findings. So the fact that you're seeing this huge abscess with the cavity, and boy, that's a lot of patient disruption and damage. So most of them are, surgeons for abscess. So, this is their abscess, and this is a big one.
Exactly.
I guess I look at it from an opposite perspective. Because of the abscesses, because we actually see it on TV. Again, if you put the, you have to look at a patient's comorbidity process. Would put that aside, I would push this gentleman to go to surgery.
Absolutely.
Sooner and not later. And there's actually, I think there's a tendency actually to move forward to push patients to undergo surgery for endocarditis earlier than later. And the idea of sterilizing the blood, I think there's just a lot of back and forth about how important that is, and I'll be honest, I don't think we ever clarified that point. But I think for him, if he's a viable candidate, I will push him towards surgery back.
Yep. Absolutely. No, and even with all the high-risk comments, that was still kind of the recommendation was, if you want to treat this aggressively, we do the antibiotics, we go to surgery, and again, in this particular case, it was more of a social side of things. The family felt like it wouldn't be something he would agree to, but I felt like it was a very impressive image, and there's, like you said, there's endocarditis and there's abscesses, and then this one I thought was a very dramatic presentation.
So to me, the most striking thing is the size of the vegetation, and that in and of itself it can be an indication for surgery. To me, as a guy doing TE for a long time, large vegetation, and I think there's more so than an abscess necessarily. There's valvular destruction, and there's perk right through the middle, destroyed. So if he's a viable surgical candidate, that has to be on the table. But if he's going into it with some dementia and this is a valid time.
Yep, absolutely. All right, so I'll go very quickly. As you guys know, I'm chatty, so I'm going over what I expected.
So, no heart murmur, huh?
Well, at least her report.
Was there any evidence of here because of the degree of mitral regurgitation? It looked to me as though there should be some elevation in the left atrial pressure, and so I'd like to see the chest x-ray, and I'd even like to see a right heart catheterization, of course, because as Kevin Harris said, the indication for surgery is acute heart failure or the size of the vegetation. And when the mitral valve is involved like that, I would want to have more information. Also, that you didn't show anything about the aortic valve. Was that not involved in the infection?
There was no vegetation, no abscess. It was thickened, and there was some mild aortic stenosis, but we were looking on all of the valves, and I originally had all the pictures, but I kept crashing the presentation. But as hard as I looked and my attending looked, we could not find any other vegetations, which we were very surprised about because we would expect to see it. So let me see if I can make it to the next case. I'll try to go through this quickly. So endocarditis, just in case, to make a very quick review, an infection of the endocardial surface, usually one or more of the heart valves, but it can include devices as well. There was a lot of arguing back and forth about the incidence. Is it going up? Is it going down? Does it depend on where you are? And I think that's probably the truth is it depends a lot on where you are, whether your rheumatic disease is going down, whether your population is aging and getting more devices. Need a high index of suspicion, which I think the ID provider in this case had a very high index of suspicion. And of course, it requires a multidisciplinary approach and the use of the Duke criteria. We all think about IV drug use when it comes to risk factors for endocarditis, but really a lot of information has come out regarding poor dental hygiene. And it's not every day that I get to use for a cardiology conference a reference from the Journal of the American Dental Association. So I figured I'd take advantage of that moment. Of course, structural heart disease, hardware, hemodialysis always worries us. But you know, looking at this, even just your age, being over 60 years old, will get you there. This gentleman did have poor dentition, but I think it's hard to know if the enterococcus came from there. We won't go over all of the Duke criteria, but I did want to point out that enterococcus, even though I'm not finding it, here it is on the list of the common endocarditis. Also, that your Duke criteria can give you a definite infective endocarditis possible, and then rejected makes me a little nervous because you might just not have met the clinical criteria yet, like we might get a few minutes to talk about. And then it's one of those areas where those of us who enjoy imaging really get our pick, and it doesn't matter which type of imaging you like, there might be a role for that type of imaging. Of course, echo is still paramount, and all the guidelines comment on how it's okay to get a TTE first, but it does not mean you don't get the TEE. And I think most people will get a TEE if you're worried about endocarditis after getting a quick TTE screen. Also, CT has been helpful in looking at these abscesses and looking at paravalvular extension. We did have one patient not too long ago where we were able to diagnose an infection based on the CT showing an abscess right around the aortic root. And he had a mechanical valve, so with the echo it was very hard to really look at anything. The cardiac MR, I get the sense, can be used in a similar way. I have personally not been involved in a case where we use it, And they also commented on assessing the degree of subendocardial involvement, which if I understand correctly, is the same way you look for a subendocardial scar or inflammation. You can kind of differentiate which areas it's involving. And then in the cases of patients with prosthetic valve endocarditis, which I've gotten to see here a couple of times, you can also get an FDG PET or a PET CT to help you try and localize whether there's actual inflammation there, and that can help you figure out if there's an active infection. One of the reasons, other than the fact that I find endocarditis interesting, that I brought it up is because there was this very good state-of-the-art paper that I got to read earlier this year. I'd love to say I read it in January, right when it came out, but I'm running way behind usually. But it had some very nice topics on endocarditis. And of course, they had their algorithm, and I just wanted to show that, again, this is another group of people that says, sure, get the TTE, but it's not an or TEE, it's an and TEE most of the time, even if you make the diagnosis, like in our case, to try and characterize it better. Oh, please.
I was just wondering if you or David or any of the MRI readers could comment on using MRI for the for looking at endocarditis. I don't have much experience with that. So.
Yeah, and I haven't seen it personally from what I read. Again, similar to CT and able to define subendocardial, but I'd love to hear if there's anything else.
I think there's a couple of things you can use MR for. So one is determine the degree of insufficiency, whether that's AI. I think MR in general echoes much better, kind of the gold standard. You can certainly look for embolic phenomena. MR will be good for that. I think in terms of looking at valvular vegetation, because everything's so mobile, MR is not the best bet. In terms of looking at assets, CT has better fixed, so that's a better way to go. In a setting when you have prosthetic valves, whether it's valid or bioprosthetic, the issue is a lot of artifacts generated in the MR, so you can have to test whether it is actually healthy.
All right.
This can actually, excuse me, Dr. Lynn is going to be speaking next week at Grand Rounds precisely about
There you go. So there's a teaser for next week, and then looking at of course there's multiple guidelines. I didn't focus too much on the ID guidelines, and they've got their own endocarditis guidelines for the antibiotic management. But the European guidelines did have some very nice summary slides that came with them, so I borrowed this from there. And of course, I don't expect anyone to read through this whole slide. It's very busy. But they did comment on the fact that approximately half of patients with infective endocarditis will require surgery. And even though half of patients sounds like a big number, I was surprised. I thought it was going to be a little higher. So I don't know if maybe that's a regional difference in how things are managed. Or maybe, I'm just biased because we see the cases in-house that do poorly and that wind up needing surgery. Then, of course, we've got a completely different guideline from the American College of Cardiology and the American Heart Association. And, of course, we always focus a lot on your Class 1 indications. And people have touched on the fact that heart failure due to valvular destruction is one of the big parts of why you operate on these patients. There's also mention of electrical activity here. And nobody's mentioned on the fact that he had a right bundle branch block and a left anterior fascicular block. At the moment, we of course didn't know those were new, but when we kept getting records from the VA, eventually we were able to find an EKG from not that long ago that did not show those conduction abnormalities. And then of course, then you fall into your 2As and your 2Bs where it might depend on the microorganism. But just in case, because when you have more than one guideline, it can get confusing, these folks that did the state-of-the-art also were nice enough to compare them for us. And again, I don't expect anyone to go through this whole table, but the nice thing is the indications themselves are very similar. And then the one difference is AHA-ACC will say the higher risk folks, they don't really give you a timeline. They say during index admission, before finishing a full course of antibiotics, whereas the Europeans, like we were chatting, will give you the emergency versus urgent versus this kind of urgent elective that they talk about. And that, if you see here on the bottom, it'll be 24 hours within a few days, and then after 1 to 2 weeks of antibiotics. So even when you do the elective, you know, and the quotations there are important, it's still within 1 to 2 weeks. It's not something that you schedule for a few months out. Of course, there's all sorts of controversial, or not controversial, but there's all sorts of topics that are constantly being looked at with endocarditis. I put in just the table they included for TAVR because I know TAVR is something we do here. But there could be an entire meeting just talking about endocarditis prophylaxis. The guidelines have changed. A lot of people feel like they've become too conservative, and that might drive some of the higher incidence. So, you know, I'd love to hear from the valve folks here or from the congenital heart disease folks here how they feel about those new guidelines. I know I've run into it once with a clinic patient where they used to get prophylaxis. Now they wouldn't get prophylaxis based on the guideline, and that made the patient very nervous, the providers very nervous, and we actually wound up giving prophylaxis to that patient. And of course, they give you a nice summary slide with, I think, all of the things we've talked about. There's a big drive outside of cardiology, just in hospitals in general, including cardiology, to reduce hospital-acquired bacteremia, of course, Foley, central lines, all of those things. We talked about the dental and prophylaxis, which are some of the hot topics right now when it comes to endocarditis. Another very interesting part that came up in the conversation with the letters to the editor and the author was use of aspirin for prophylaxis of endocarditis, which is something I honestly was not familiar with, and if anybody was, I'd love to hear about it and if anybody's using it. On the responses, there was comments about one small retrospective trial where they used it and maybe thought there was and showed there was a slightly lower incidence, but I feel like that would be a very difficult topic to study because the incidence is so low. Of course, the mechanisms they posed they intuitively made sense, talking about how the bacteria can use some of the same mechanisms to adhere to the endothelium and how aspirin might help. So I'll try to sneak in just in a couple of minutes another one. And this was a very different story. This was a young man. I believe he was 32, early 30s. No known prior medical issues. Didn't really go to the doctor, didn't have to see the doctor because he never really had any problems. But he did have an opiate addiction problem, and he did use IV drugs. He was found by the people who were renting a room to him. He was found down, unconscious, with some other people in the room. EMS were called. They found him. He was they were worried he had aspirated, and he was hypoxic, and he wasn't breathing enough times per minute. And the people around him had actually passed away from a drug overdose. So of course, this gentleman came in, and he came in with a much more typical story for endocarditis. With our other patient, when he came in, people were thinking meningitis, UTI, and ID brought up the concern of endocarditis. With this patient, it was kind of the opposite. He came in, and from the get-go, everybody was worried about endocarditis. Overnight when he came in, they, of course, drew blood cultures, and those came back positive for gram-positive cocci again. And so an echo was ordered. There was also concern about, like I mentioned, aspiration pneumonia. His x-ray looked terrible. They were having trouble venting him. And so these were the images of the first transthoracic echo we did. And of course, we've got our parasternal lung there at the top with some error that came up, but it's still good enough to get to see at least a little bit of that mitral valve. And they gave us a nice zoomed in image there where there's very little regurg. And here the valve, what you can see of it, in my opinion, looks okay, and there wasn't really much of a regurgitant just there. And again, I wish I could show you all the pictures, but that was really making the presentation unmanageable. So of course, with that transthoracic echo, we couldn't really find anything that looked like endocarditis, but our suspicion was very high. We were not sold on it, and we decided we were going to do a transesophageal echo, and the team was in agreement with that, and the patient at that point was intubated, but his healthcare agents were in agreement with that. And again, focusing a lot on the mitral valve, not to spoil, but we were looking a lot at that mitral valve, and at the time, as hard as we looked, we could not find any vegetation, and we could not find an abscess. And I don't know if anybody's seeing something here that I might have missed around that mitral valve and that mitral valve annulus that they say, oh, I would have looked at that a little more. But in retrospect, what I think is maybe around this area, we might have been able to get a hint. In any case, even with the TEE, we weren't quite satisfied, but the patient was improving on antibiotics, and the team had kind of said, well, you know, it sure seems like it's this pneumonia, and he's getting better, and he wound up getting extubated, but we still said we want another echo. So they kindly ordered another echo for us later during his stay. He wound up being in the hospital for a long time, and I tried to put up some equivalent images on this time, and just like on the paper where you've got to find the differences between the two pictures, I don't know if anybody wants to volunteer for what the difference is in this one. I'm running a little late, so if nobody...
There's a lot of MR on the newer echo.
Yep, so of course...
Right lower picture.
Yep, over here. So of course we got very worried when we saw that TTE. Even though he was improving clinically, his blood cultures had cleared while on antibiotics. We said, guys, we want to do a TEE again. And so then we did a TEE. And again, we couldn't find the vegetation, but if you guys look at the image at the top right, that area where I was pointing before, now we've got this. So it's not like our other patient where it was a vegetation moving up and down and hanging right around where the valve is. This one was sort of all in that mitral annulus. And the reason I mentioned the images on the other echo is because even though there wasn't the vegetation, and it certainly didn't look like that, it makes you wonder if this stuff that you see here could have been a premonition of what was to come. I don't know. And with echo, obviously, it's difficult because you're not seeing the cells or the microorganism. But, you know, it raises, I thought in my mind, in retrospect, it definitely raised the question. I was very glad we kept pushing for more echoes, even though everything we found said, no, it's fine. We just couldn't believe that there was nothing there, and we wound up finding that. This was another one where, again, through the valve, we weren't catching a lot of the regurgitation where you would expect. So we kept digging and digging and eventually found this. And this one, there's not quite as much going through a fistula there, but it sure looks like there's some going through the fistula. And then, like Dr. Harris mentioned, some valve destruction there. This gentleman was young. He got his surgery, mechanical prosthesis. He's been doing great since then. He's stayed clean, has not relapsed as far as I know, or at least hasn't had an infection from it or an admission from it. So kind of a yin to the yang, a much younger patient, more of the typical case you would expect. But then the imaging wasn't impressive at all to start with. But again, if you keep the suspicion high in the right clinical context, you might run into this. I've gone over what I expected to go. I don't know if anybody's got any comments, though. I'd love to hear them. If anybody's been using aspirin for prevention of endocarditis. I want to be taught about that because I did not know about it.
Just a quick comment. I mean, what you did would be in line with the guidelines here.
Yeah.
Essentially, if you have clinical suspicion for endocarditis and your initial evaluation is negative, you're supposed to repeat either echo or TE in about a week or so. This is very interesting, morphology of the endocarditis. There is some small mobile vegetation. You can see it. It is very close to the circ. Yep.
What did they see at surgery? And how hard was it to put in if the annulus was involved, I would be concerned about the stability of the prosthesis.
Yep, and we were all worried about the fact that here you can see the coronary artery very close to where they were going to have to be cleaning up. They commented on an abscess of the mitral ring. They made kind of the same observation that it was just kind of a bizarre looking vegetation where it wasn't necessarily so much attached to the valve, but much more to the actual annulus. There was a lot of dissection that went into that annulus, but fortunately, the coronary artery was not affected, and they were able to get a mechanical prosthesis that was well seated. So it was a difficult surgery, and just kind of the location was difficult in the sense that they had to get a lot of tissue from that ring where they wanted to sew the valve into. But yeah, it was just kind of an odd location for it. All right. Any more takers? Any other questions? Well, thank you.
Please stop by and say thank you to our session sponsors, Novartis and Pfizer this week. Have a great week.
All right.
And this, and